Section 5 of the physiology handout is the physiology of cardiac muscle. And this is one of the highest yield sections for Step 1 then. If I had to pick one of the most important sections, it would be the physiology of cardiac muscle. Now, in terms of the number of pages in the handout, this, I think, is the highest yield section of physiology. But I did mention that the material covered earlier is a prerequisite for this section here. You must have understood some of the earlier material to deal with this section. Now, the first chapter here is the electrical activity of the heart. The prerequisite for this section was the excitable tissue section, where we went through the principles of how ions flow through channels. Also, we covered the action potential of a neuron. That is also a prerequisite for this section. When we go through the action potential of a regular contracting ventricular fiber, then it is important that you've gone through and understood the action potential of a neuron. Now, the first page here is a table that gives you some characteristics of ventricular muscle. It is important to go through this before we go through the actual action potential. Now, there are 3 ions we are going to consider in a ventricular action potential. The first one in the table here is potassium. Now, the concentration of potassium outside the cell is fairly low. The concentration inside the cell is much higher. Now, the equilibrium potential for potassium here is slightly different than in the neuron. It is about minus 94 millivolts. Now, under resting conditions, the permeability to potassium is extremely high in this tissue. In regular contracting ventricular muscle, as we'll see in a few minutes, under resting conditions, you have an extremely high permeability to potassium, and that means under resting conditions, the resting membrane potential is very close to potassium equilibrium potential. It doesn't quite get there, but under resting conditions, because the permeability to potassium is extremely high, the resting membrane potential is very close, but does not quite reach potassium equilibrium potential then. The second ion we have to deal with is sodium. Now, the concentration of sodium outside the cell is high. The concentration inside the cell is low. Now, the equilibrium potential for sodium is, again, a positive potential. However, this is more positive than we talked about in the neuron. And the point here is that during the action potential, you never reach plus 70 millivolts in a ventricular fiber. Therefore, you always have a net force on sodium directed inward. So during the ventricular action potential, if you have a sodium channel open, there will always be a sodium influx through that channel. You never reach sodium equilibrium during the ventricular action potential. But just like in the neuron, under resting conditions, the permeability to sodium is extremely low. Under resting conditions, all the channels that allow sodium to pass through are more or less closed. Now, the third ion we have to deal with here is calcium. Now, the calcium concentration outside the cell may appear low, but inside it is almost zero. And because the free calcium concentration inside is almost zero, the equilibrium potential for calcium is a very, very positive number. And again, because you never reach calcium equilibrium during the action potential, there will always be a net force directed inward for calcium, which means if you have a calcium channel open, there will always be an influx of calcium. Now, just like sodium, under resting conditions, all the calcium channels are closed. Therefore, the permeability to calcium is very low under resting conditions. Now, we'll start again here with the channels involved. And I want to be very specific going through here then. There are 4 channels we have to consider. Now, just like every other cell in the body, we have these ungated potassium channels. And these ungated potassium channels are always open, and because we never reach potassium equilibrium, we will always have a potassium efflux through these channels. It is very important to remember that we never reach potassium equilibrium. Therefore, there's always going to be an efflux of potassium through these ungated channels. Now, the second channel we have to consider is the voltage-gated or voltage-dependent sodium channel. Now, these channels are identical to the ones we talked about in the neuron action potential. These channels are closed under resting conditions. Depolarization is the signal that causes these channels to open fast, then they close fast. So they open fast and they close fast, and these channels will be open during depolarization. Now, because these channels open fast and close fast, these are the channels, as we said earlier, that are referred to as the fast channels. Now, in most cases, they will refer to heart muscle having fast channels. So it's these voltage-gated sodium channels that are the fast channels in heart muscle. Now, the third channel we have to deal with will be the voltage-gated or voltage-dependent calcium channels. Now, just like the voltage-gated sodium channels, these are closed under resting conditions. Now, depolarization is again the signal that causes these channels to open and then close. But these channels open more slowly and close more slowly than the sodium channels. Therefore, these channels are open later during the action potential. They are more or less open during the plateau phase. Now, because these channels open slowly and close slowly, they're referred to as the slow channels. So in heart muscle, the fast channels are the voltage-gated sodium channels. The slow channels are the voltage-gated calcium channels. And that is appropriate terminology in this situation. Now, the fourth channel we have to deal with is a voltage-gated potassium channel. Now, in heart muscle, there's a large number of different voltage-gated potassium channels, so we're oversimplifying a little bit here, but this is good enough for our purposes in order to understand the ventricular action potential. Now, these voltage-gated potassium channels are different than the ones we talked about in the neuron. Here, the channels are open under resting conditions. Therefore, under resting conditions, we have the ungated potassium channels open. We have the voltage-gated potassium channels open because all the potassium channels we are dealing with here are open under resting conditions. We have a very high conductance to potassium under resting conditions, and therefore we're very close to potassium equilibrium. But we have not quite reached potassium equilibrium. Therefore, there will be an efflux of potassium through both the ungated and the gated potassium channels. So just to repeat that, under resting conditions, we have not quite reached potassium equilibrium, and therefore there will be an efflux of potassium through the ungated and the gated potassium channels. Now, these gated potassium channels are very unique. Now, the details are in your handout here. Now, just being very careful. Depolarization is the signal that causes these channels to start closing. Now, I'm being very careful with my words here. The voltage-gated potassium channels are closing during depolarization. So they're in the process of closing down during depolarization. A very important point is that these channels are closed during the main part of the plateau phase. So the voltage-gated potassium channels are closed during most of the plateau phase. Now they start reopening in the latter part of the plateau phase. Now that is a detail that's not important. You simply have to remember that these channels quickly reopen as you enter repolarization. So the channels quickly reopen again as you enter repolarization. Now that represents the main characteristics of the channels we have to deal with. Now the main challenge here is to understand what is going on in each phase of this ventricular action potential right here. Now this is a ventricular action potential. It is the action potential of a regular contracting ventricular fiber. It is sometimes called a fast responding fiber. Now it's called a fast responding fiber because it has fast channels. So a ventricular fiber, a regular contracting ventricular fiber, is a fast fiber because it has fast or voltage-gated sodium channels. Now for some reason, they label the various phases with numbers. Now the resting stage here is phase 4. And notice in a regular contracting ventricular fiber, you have a stable resting membrane potential. You have a stable phase 4. And that is a characteristic of the regular contracting fibers in the heart. The regular contracting fibers in the heart will have a stable resting membrane potential. The specialized fibers in the heart are quite different, and we'll talk about those later. Now, you should recognize that this must be a regular contracting ventricular fiber because it has a very long plateau phase. So a stable resting membrane potential, phase 4, and a stable, very long plateau phase characterizes the ventricular action potential. Now, going back to the numbering here, the depolarization phase is referred to as phase 0. Now, once you finish depolarization, there'll be a slight repolarization, and this is referred to as phase 1. Not highly tested on the exam, but at the beginning of the plateau phase, you have a slight repolarization. The main part of the plateau phase is phase 2, and then the repolarization is phase 3. Now, we're going to go through this phase by phase, and all the details are on the handout. Now, what we're going to try and do is to correlate each phase with a conductance change and then with the major ion flowing. Now, during the depolarization phase, we will have an increase in sodium conductance. Why? Because the fast channels are open. What you have to remember is the fast channels open quickly, and they're open during the depolarization phase. Because the fast channels are open during phase 0, during this phase we have a sodium influx, and it's the sodium influx that causes depolarization. Therefore, then, the depolarization of a regular contracting ventricular fiber is basically the same as the depolarization phase in the neuron action potential. Both are caused by the opening of fast sodium channels, and it's an influx of positive sodium ions that is causing depolarization. Now, after phase 0, as I said previously, we'll have this phase 1, which is a slight repolarization. Now, if you've read review books published about 4 or 5 years ago, they will probably say that phase 1 is due to a chloride current. But we now know it is not a chloride current. Phase 1 is due to a special potassium channel. Now, we're not going to get into the details because it's not tested on the exam. But just remember that phase 1 is due to a special potassium channel. It is a potassium efflux through the special voltage-gated potassium channel. But other than that one point, then, it is not important for step 1. The most important phase is phase 2. Now, we have to be careful here because several things are going on in phase 2. First of all, during phase 2, this is the phase when the slow channels are open. It is phase 2 when you have the slow voltage-gated calcium channels open. Therefore, during phase 2, you will have a calcium influx. Now, very big point for step 1. The calcium influx that occurs during phase 2, the calcium ions flowing into the cell not only participate in contraction, but those calcium ions will also trigger the release of additional calcium from the sarcoplasmic reticulum. So just to repeat that very important point, the calcium that flows in through those voltage-gated calcium channels not only participates in the contractile response, it will release additional calcium from the sarcoplasmic reticulum. The most important phase of the ventricular action potential is the plateau phase. And there are several things going on here. First of all, during the plateau phase, the voltage-gated calcium channels are open. So during the plateau phase, we have an increased conductance to calcium. And therefore, we will have an influx of calcium during the plateau phase. Now, a very important point here is the influx of calcium through the slow channels during the plateau phase not only participates in contraction, but that influx of calcium also releases additional calcium from the sarcoplasmic reticulum. Very important point for step 1. So just to repeat that then, during the plateau phase, we have an increased calcium conductance, and the influx of calcium through those slow voltage-gated calcium channels not only participates in contraction, but that calcium releases additional calcium from the sarcoplasmic reticulum. Now, the other important aspect of the plateau phase is during the plateau phase, we have a very low potassium conductance because the voltage-gated potassium channels are closed during this phase. We have a very low potassium conductance. However, the ungated potassium channels are still open. So during the plateau phase, we continue to have an efflux of potassium through the ungated channels because they're always open. Now, it just turns out that during the plateau phase, the inward flux of calcium almost exactly balances the efflux of potassium in terms of charge, and because they balance each other in terms of charge, we have a fairly stable membrane potential during the plateau phase. Now again, this is an important point for step 1. Consider that if the voltage-gated potassium channels did not close during depolarization, if the voltage-gated potassium channels did not close during depolarization, you would have a very high conductance to potassium during the plateau phase. You would have a massive potassium efflux and early repolarization. It is important to know that the closing of the voltage-gated potassium channels delays repolarization, and produces a very stable plateau phase. You cannot produce a stable plateau phase unless you close those voltage-gated potassium channels. And that is an important point to understand. Now, the last phase to consider here is repolarization. And what is going on in the early part of repolarization are two things. First of all, you are closing the voltage-gated calcium channels. So as you enter repolarization, the calcium influx is terminated then. So because you're closing the voltage-gated calcium channels, you are terminating calcium influx. The other feature that's important, as I said earlier, as you enter repolarization, you are reopening the voltage-gated potassium channels, so potassium conductance is increasing. Now, as you enter repolarization, you are a long ways from potassium equilibrium. You're reopening voltage-gated potassium channels. Therefore, you get a massive potassium efflux, and that causes repolarization. We said earlier in discussing the neuron action potential that potassium efflux always causes the repolarization phase in any action potential, and that, of course, applies to a ventricular action potential. Now, another good point to test in step 1 would again involve the voltage-gated potassium channels. Suppose you gave a drug that prevented the opening of the voltage-gated potassium channels. That means as you entered repolarization, you would not have a massive potassium efflux. You'd have a much smaller potassium efflux, and that would cause a slower repolarization. Now again, very important point. So just to repeat that then, as you enter repolarization, if you do not open the voltage-gated potassium channels, you are left with only the ungated potassium channels, and that will result in a slow efflux of potassium, and therefore repolarization will take longer. You will still repolarize, but it will take longer. Now, just to summarize all this by asking specific questions to make sure there's no misunderstanding, if we go through and look at the conductance changes then, in phase 0, we have an increased sodium conductance, and the influx of sodium causes depolarization. In phase 2, we have an increased calcium conductance, and the influx of calcium then participates in contraction and releases calcium from the sarcoplasmic reticulum. In phase 2, we also have a reduced potassium conductance. The reduced potassium conductance minimizes the efflux of potassium. That balances the influx of calcium and permits the stable plateau phase. During phase 3, we have a sudden increase in potassium conductance. We get a massive potassium efflux, and that causes repolarization. Now, just a few other points here. I already mentioned if you give a drug that blocks the opening of the voltage-gated potassium channels, you will still get repolarization, but more slowly. Now, this is similar to the question I asked in the action potential of a neuron. In the action potential of a neuron, I also asked the question, if you give a drug that blocks the opening of the voltage-gated sodium channels, the answer there was that would block the action potential. But in a ventricular action potential then, in a ventricular muscle fiber, if you give a drug that blocks the opening of the fast channels, you do not block the development of an action potential. Because in regular contracting ventricular fibers, you have the slow channels. And you should realize the slow, voltage-gated calcium channels can replace the fast channels. You will still get depolarization, but depolarization will be due to a slower influx of calcium. And that is another good point to test on step 1. Now that finishes off a complete description of the ventricular action potential. This is the most heavily tested action potential on step 1. I would go through that very carefully and understand all the details, including those few points that are in the handout that we did not mention here. Now, the next figure here simply correlates the ventricular action potential, illustrated here, with the mechanical contraction of the ventricle, illustrated right here. Now, the point of this figure is to simply show that this electrical event is a very long event compared to a neuron action potential. This action potential is a very long electrical event compared to the action potential in a skeletal muscle fiber. Now, you remember what we said earlier. In skeletal muscle, because the electrical event is very short, we can have several electrical events for every mechanical event, and multiple electrical events permits tetanization of the muscle. Whereas if we look at cardiac muscle, because the action potential is a very long event, then we can basically only have one electrical event per mechanical event. You have a very long absolute refractory period, and you cannot have another action potential until most of the contractile response is over. Because in ventricular muscle, you have a very long absolute refractory period, you generally have one electrical event per mechanical event. And if you have one electrical event per mechanical event, it is impossible to saturate the interior with free calcium. It is impossible to tetanize heart muscle. You should understand why it is possible to tetanize skeletal muscle, but why it is impossible to tetanize heart muscle. That is the important point right here. Now, there is another action potential that they could test, and this is illustrated on this page here. Briefly, we'll take a look at action potentials of specialized cells in the heart. Now, specialized cells in the heart include 3 different cell types. They include SA nodal fibers, AV nodal fibers, and Purkinje fibers. So all 3 tissues represent specialized cells in the heart, but the only action potential they may test in terms of characteristics will be the action potential of an SA nodal fiber. And that is what we have illustrated right here. This is the action potential of an SA nodal fiber. Now, there's only 2 specific points about this action potential they're likely to test on step 1. First of all, SA nodal cells do not have very many fast channels. Therefore, depolarization is not due to an influx of sodium through fast channels. Rather, it is due to the influx of calcium through slow channels. So the depolarization of an SA nodal fiber is due to the influx of calcium through slow channels. The other characteristic is typical, as I said earlier, for every action potential. Repolarization is due to a potassium efflux. So in this action potential, there's only 2 points to remember for step 1. Depolarization is calcium influx through slow channels, and repolarization, like every other action potential, is due to a potassium efflux. Now, another characteristic that is not only present in SA nodal fibers, but in all specialized fibers. Now, we're going back and generalizing now. One characteristic that is present in all specialized fibers is an unstable phase 4. In phase 4, you always have, in these fibers, a gradual depolarization towards threshold. Now, this depolarization is given a special name. It is called either a pacemaker potential or a pre-potential. And because you have a gradual depolarization, you will eventually reach threshold and the cell will automatically fire. A major characteristic of specialized cells is because they have a pacemaker potential, they will fire intrinsically. They do not need an external stimulus then to generate action potentials. Once this gradual depolarization reaches threshold, these cells will automatically fire. Now, you can read in textbooks a theory to explain this gradual depolarization. But the problem is the theories presented in different textbooks will vary. Now, what we have on the handout here is that this gradual depolarization is probably due to a decreased potassium conductance, and that is one theory. But some textbooks will say that this depolarization is due to an influx of sodium. Other textbooks will say it is due to an influx of calcium through slow channels, and some textbooks will say it's a combination of all 3 mechanisms. Because it is not clear what the mechanism is, it will not be tested on step 1. However, now we're going back to SA nodal cells again. SA nodal cells are innervated by sympathetic and parasympathetic neurons. And when you activate these neurons, there will be characteristic changes in this pacemaker or pre-potential. You don't have to know the mechanism responsible. You just have to know the consequences. Now, on the next slide here, what we're showing will be the consequences of stimulating sympathetics to the SA node. If you stimulate the sympathetics to the SA node, what you see is an increase in the slope of the pre-potential. You simply remember sympathetic neuronal stimulation to the SA node will increase the slope of the pre-potential. If you increase the slope of the pre-potential, then you will reach threshold sooner, and therefore the intrinsic firing rate will increase. On the other hand, if you stimulate the parasympathetics, what you observe for sure is a hyperpolarization of phase 4. So parasympathetics will at least cause a hyperpolarization. If you hyperpolarize, it will take longer to reach threshold, and therefore the intrinsic rate will slow down. Now, in addition, some people also teach that the slope is decreased. That will further delay the development of the action potential. But again, the bottom line point is, if you stimulate the parasympathetics, you will at least get a hyperpolarization at the beginning of phase 4. It will take longer to reach threshold, and therefore the intrinsic rate will slow down. Now, mechanisms, again, are not important for step 1. Now, the next couple of topics here are very easy to deal with. The first one is conduction pathways. Now, we do have a figure in the handout. The details in that figure are not that important for step 1. You simply have to know the pathway of conduction. Now, in a normal heart, the pathway starts at the SA node. then the action potential will spread over the atrial muscle, then to the AV node. Now, don't forget, there is a delay in that action potential getting through the AV node, and once it gets through, it goes through the Purkinje fibers and then to the regular contracting muscle. Now, that is the normal pathway of conduction. Now, the other parameter here is velocity. Now, don't forget, velocity is speed. Now, all you have to remember is the fastest conducting fiber, the fiber over which the action potential goes faster in terms of centimeters per second, is the Purkinje cell. The slowest conducting fiber in the heart is the AV nodal fibers. And a third fiber, if they give you one, simply fits between the two. You have to know the fastest conducting fiber and the slowest conducting fiber. Now, automaticity is also a very easy topic to deal with. Automatic cells in the heart are cells that fire without an external stimulus. So the automatic cells in the heart are the specialized cells in the heart. Now, you have to know that the SA nodal cells will have the highest intrinsic rate, and Boortz calls these cells the primary pacemaker of the heart. Now, the AV nodal cells have the second highest intrinsic rate, and they can be referred to as the secondary pacemaker of the heart. If the SA nodal cells fail to fire, then the AV nodal cells will take over as the pacemaker of the heart. And the slowest firing, the slowest intrinsic rate of firing, will be the Purkinje cell in the ventricle. Now, there is a standard question, and it's a trick question in this area. The standard question is the following. If the heart rate of an individual is 100 beats per minute, if an individual has a normal heart and it is beating 100 times per minute, the question is, what is the firing rate of the AV nodal cells? Well, if the heart rate is 100 beats per minute, the firing rate of the AV node must also be 100 times per minute. At a heart rate of 100 beats per minute, every cell in the heart is beating 100 times per minute. Now, the answer to that question by some students has been 60 per minute. 60 per minute is the intrinsic rate of the AV node. If the SA node is knocked out and no longer functioning, then you get the intrinsic rate of the AV node taking over, and then that would be 60 per minute. Then every cell in the heart would be beating at 60 times per minute. So that is just a very simple, tricky question that you should be aware of. Now, the next section of the handout is electrocardiography. This is considered a supplemental topic. It is not a high-yield topic for Step 1. It's a very complex subject and generally not tested on Step 1. So you have the option of bypassing this topic because it is very unlikely you'll get a question in this area. Now, we did introduce a small amount of pathophysiology here. They have been testing heart block on Step 1, and therefore you should understand the 3 different types of heart block. First degree or partial heart block is characterized by simply a slow conduction through the AV node. In this situation, then every impulse gets through. It just takes longer to get through that AV node. Now, in Step 1, it is unlikely they're going to give you an abnormal electrocardiogram to interpret, but in first-degree heart block, you identify this state by noticing the PR interval is increased then. So that's how you would identify. In addition, you should realize that parasympathetic stimulation to the heart can induce first-degree heart block. A large parasympathetic input will significantly slow conduction through the SA node. And that is a specific point that they could test. Now, second-degree heart block is more likely to be tested. Second-degree heart block is a situation where some impulses are not transmitted through the AV node. Some are transmitted, but some are not transmitted. Now, we have the two subcategories of second-degree heart block in the notes. It's not high yield, but it is worth going through and knowing the two subdivisions of second-degree heart block. Now, this is the abnormal state where they could present the electrocardiogram because it's very simple to interpret. If they give you an electrocardiogram to interpret here, you identify second-degree heart block as a situation where most of the P waves will be followed by a QRS complex, but every once in a while a P wave will not be followed by a QRS complex. So every fourth or every fifth P wave then would not be followed by a QRS complex. Very easy to identify, and therefore we put the electrocardiogram in because it's a possibility that is the way they could test it on step one. Now, the other heart block is complete or third-degree heart block. In this situation, no impulses are conducted from the atria to the ventricles, and therefore the atria and ventricles will be beating independently. Now again, we did not put an electrocardiogram in because this one would be very difficult to interpret. However, they could ask you, what would you be looking for in an electrocardiogram to identify third-degree heart block? And there's two things you should be looking for. Because the atria and ventricles are beating independently, in the electrocardiogram, there should be no correlation between P waves and QRS complexes. So the first characteristic is that there should be no correlation between P waves and QRS complex. Secondly, then, because the pacemaker tissue in the atria, or the pacemaker that is driving the atrial tissue, will have a higher intrinsic rate than the pacemaker that is driving the ventricular tissue, the frequency of P waves will be greater than the frequency of QRS complexes. So the second characteristic is that the frequency of P waves will be greater than the frequency of QRS complexes. Now, the last aspect here is Einthoven's triangle. Again, this is a supplementary topic. It is not high yield for the exam, and the electrical axis for the heart is also not a high yield topic. The only question I think they may ask about the electrical axis is, if you have a left axis deviation, this can be caused by hypertrophy of the ventricular tissue. On the other hand, if you have right axis deviation, this can be caused by right ventricular hypertrophy. That is probably the only question that they would ask in this section. It is a very complex topic and not likely to be tested on step one. Now, this finishes off the electrical activity of the heart. And as I said, this was a fairly high yield topic for step one. This is where most of your questions will come from, but don't forget that earlier material in excitable tissues was a prerequisite for this material. It's important to go over that material as well as this. Now, the second chapter in the cardiac section is the section in heart muscle mechanics. And again, we have a prerequisite here. The prerequisite, as I mentioned earlier, is skeletal muscle mechanics. If you understood the material in skeletal muscle mechanics, this material becomes a lot easier to deal with. And again, it is this material that they're more likely to test on step one. Now, I want to start off by defining a few terms here. And these are very important to completely understand. The first one is systolic performance. And you have to understand exactly what they're referring to when they're referring to systolic performance. Now, by definition, systolic performance is the overall force generated by that ventricular muscle during systole. So if they're asking you what is happening to ventricular performance, you simply think force of ventricular contraction. If you conclude you generate a greater force during ventricular contraction, systolic performance will improve or increase. On the other hand, if the force you generate during systole decreases, then that means a decrease in systolic performance. So just to repeat the main point then, systolic performance is the overall force generated by that muscle in systole. And an accessory, also very important point is that this force is determined by the number of cross bridges cycling during contraction. So putting it all together, it is the number of cross bridges that cycle between the actin and myosin that determines systolic performance. The more cross bridges that cycle between the actin and myosin, the greater the force you generate in that muscle and the greater the systolic performance. If you decrease the number of cross bridges cycling, then you will develop less force during systole, and therefore systolic performance will decrease. You have to associate the number of cross bridges cycling with the force of contraction, which means systolic performance. Now, that is a slight oversimplification, but that will basically fit our purposes here. Now, getting to something even more important, the two variables that affect the number of cross bridges cycling will be preload and contractility. Now, there's always been a problem in the past here with a few students. The problem in the past has been some students seem to assume that contractility and the force of contraction are synonymous. They are not synonymous. You can have a change in the force of contraction that has nothing to do with contractility. In a few minutes, you will understand that contractility is simply one factor that determines the overall force of contraction. Now, just to repeat that, because that can be a little confusing, you should not equate the force of contraction with contractility. You can change the force of contraction without a change in contractility. You have to realize that contractility is just one of two factors that determines the overall force of contraction. Now, trying to be very careful here. As I said, there are two variables that determine the force of contraction. Therefore, there are two variables that determine the number of cross bridges that cycle, and two variables then that determine the force of contraction and systolic performance. Now, the first one is preload. Now, again, being very careful here. You have to accept that preload is one variable that affects the number of cross bridges cycling and therefore affects systolic performance. If you change preload on ventricular muscle, you will change the number of cross bridges cycling and you will change ventricular performance. Now, this is a general statement that will apply in almost every situation, including most clinical situations. There are exceptions, but the general statement is, if you increase preload on ventricular muscle, you will almost always see an increase in the force of contraction. Now, like I said, there's a few exceptions to that, but in almost every clinical situation, if you increase preload, you will get at least a slight increase in the force of contraction. Now, the other variable is contractility. Now, we're going to assume that contractility is completely independent of preload. We're going to assume the second independent variable that affects the number of cross-bridges cycling and systolic performance is contractility. Now, it is very difficult to define contractility without using the word preload, because these are the two variables. Now, there's different ways of defining contractility. This is one way that will work. In other words, if you have a change in the force of contraction, but you can't explain it on the basis of preload, therefore, by default, you must have changed contractility. So just to repeat that then, if you get a change in the force of contraction that you cannot explain on the basis of preload, you can more or less assume you've changed contractility, because there's only two variables that affect the force of contraction. One is preload and the other is contractility. To give you an example, if a person develops low output heart failure, if a person develops congestive heart failure, then the force of contraction of heart muscle decreases. This decreased force of contraction cannot be explained on the basis of preload. Therefore, by default, in low output heart failure, the loss of performance must have been due to contractility. If you can't explain it on the basis of preload, you have changed contractility. Now, like I said, you just have to accept that these are two more or less independent variables. I know recently they have demonstrated they're not totally independent, but for our purposes, we can assume they are independent. Now, the first one we'll consider in most detail will be preload. Now, on the next slide here, we start off by simply defining preload again. And the definition is almost identical to what we talked about in skeletal muscle. If you preload the muscle, you're placing a load on that muscle before the muscle contracts. And one consequence will be the muscle develops passive tension, and the second consequence is the muscle and the sarcomere will stretch. Therefore, preload on left ventricular muscle can simply be considered the pre-stretch of the muscle, the pre-stretch of the sarcomere. The greater the preload of that muscle, the greater the pre-stretch of the sarcomere. Now, with ventricular muscle, we do not measure preload directly. Rather, indices are utilized to measure preload. And boards or Step 1 expects you to understand the best indices of preload and the poor indices of preload. Now, as an example, we could use either the right ventricle or the left ventricle. But in most cases, we prefer to use the left ventricle as an example. Therefore, then, indices of left ventricular preload will be the following. The best indices of preload are those that are measured directly inside the ventricle. Therefore, left ventricular end diastolic volume is one of the best indices of preload on the left ventricle. An increase in end diastolic volume would mean a greater pre-stretch of the fiber, and therefore there must be a greater preload. Another index that is almost as good is left ventricular end diastolic pressure. The greater the pressure in the ventricle at the end of diastole, the greater the pre-stretch on the fiber. Now, these are the two best indices of preload on left ventricular muscle. Now, poor indices are those measured outside the ventricle as you move towards the venous system. And the further you get away from the heart, the poorer the index of preload. Now, on the next slide here, we have less reliable indices of preload on the left ventricle. An index of preload, but which is not as good as the former two, is left atrial pressure. Left atrial pressure, if it increases, would be an index of an increase in preload on the left ventricle, but it is not as good as the former two. An even poorer index would be pulmonary venous pressure. A rise in pulmonary venous pressure would indicate a greater preload on the left ventricle, but is not as good as the former indices. The poorest index we're listing here is pulmonary wedge pressure. It is the poorest index because it is furthest away from the left ventricle. Now, even though it's the poorest index, it's the standard one measured clinically because of all the ones we have considered, pulmonary wedge pressure is the easiest to measure clinically. You should realize the pulmonary wedge pressure is your clinical index of preload on the left ventricle. Now, I'm assuming everyone knows that pulmonary wedge pressure is measured from a Swan-Ganz catheter. The catheter is introduced into a systemic vein. It is pushed towards the heart through the right side into the pulmonary artery, and then it is wedge pointed downstream. And when that catheter wedges, then the pressure you record is an index of preload on the left ventricle. If you have an increase in pulmonary wedge pressure, you can conclude there's an increase in preload on the left ventricle.